We're going to get started with the program for today, and I would like to introduce our first speaker, Dr. Kathie-Ann Joseph, who is an associate professor of surgery and population health at Perlmutter Cancer Center and is also the chief of breast surgery at Bellevue Hospital Center. Let's welcome Dr. Joseph.
Good morning. Good morning. Welcome, everyone. I thank you so much for coming in this morning on a Saturday. I was thinking the other day about how many years we've been doing this program, which we've done in different venues over 2 institutions. I started this when I was a junior attending. And this is actually a very special year because I realized as I was thinking about it that this is the 15th year that we have been doing this program. I started this because when I was a second year attending at Columbia and seeing so many women coming in with advanced disease that I felt that it was important to get the word out and educate women about the importance of screening and about breast cancer in our community. So I really thank you all for coming today. And I really hope that you support us in getting the word out to more women to come to this event. And it was really important then, as it is now, to make this event free so that people can come and not worry about the cost of this event. We have a lot of wonderful people speaking today, experts in their fields, and I really appreciate the time that they're taking out of their schedules to come today to speak. We're not going to use our clickers, but I just have a couple of questions. We often use these questions every year, but I want to make sure we have a lot of veterans coming back who come every year. So I want to make sure you guys were paying attention. First question, which group of women in the United States is more likely to be diagnosed with breast cancer? We'll just do a show of hands. White women, A. Okay. B, African American women. Okay. C, Hispanic women. Or D, A and B, white and African American women. Okay, so people were paying attention, they're reading. Yes, so if this was a question that I asked about 5 years ago, we would have said A. But now African American women have caught up to white women. And so it's not a milestone that we would have wanted, but the incidence of breast cancer in African American women have caught up to white women. 2, which group of women in the United States is more likely to die from breast cancer? A, white women. B, African American women. Okay, so that's like most of the room there. C, Hispanic women. D, Asian women. Okay, so most people in the room said B. Yeah, that's kind of the point of this whole conference, right? We're trying to get the word out, not just to African American women, but African American women are disproportionately affected by breast cancer, and that's stage for stage. There's a lot of reasons why that happens. There's no one reason, but there's so many, it's multifactorial. 3, women who are at average risk for breast cancer and who have no health insurance should A, not worry about having a mammogram. Okay, I don't want to see any hands up for that one. Okay. B, should enroll in the New York State Cancer Services Program. Okay. C, should pay for their annual mammogram. Or D, none of the above. So B, they should enroll in the New York State Cancer Services Program. I'm not going to spend a lot of time talking about it right now, but if people have questions about that program, we can talk about that offline or go outside and talk to one of our navigators that can explain that program and ways that you can get a mammogram if you do not have insurance. So survivornet.com is a new website. I've worked with them. I've done some interviews with them. Some of my colleagues here in the room have worked with them and other colleagues at other institutions. You can go on their website, whether you are a survivor or if you just want to learn more, get more information on cancer. They put this on, I saw this on their Instagram site, and it really resonated with me because one of the things that I often hear from my patients sometimes is they go on the internet, and I'm trying to explain to them something about treatment, and they say, well, Dr. Joseph, I read on the internet X, Y, and Z is a good treatment, and I have never heard anything about what they're talking about. So it's so interesting that something that is could be potentially harmful to a patient gets out much more quickly than something that could be beneficial. It just spreads. So bad information, it spreads like cancer. People can sometimes be more likely to believe what they want to believe because they're scared. They just are. So this is really what this program is about. We're just trying to spread evidence-based information and get that out to you all so that you can then spread it to your friends and family. So we know that breast cancer is the most commonly diagnosed cancer among nearly every racial and ethnic group. About 40,000 women, affects over 40,000 women a year in terms of deaths. It's a second leading cause of death in women. But the good news is that more women are surviving breast cancer because we have more ways to treat it. This is the slide I was referring to in terms of which talks about the fact that the incidence, which is in pink, sorry, I don't have a pointer. If you look at the white women and black women, it's about the same. It's just that the mortality rates are higher in black women. So for every 100,000 women, 31 black women will die versus 22. And that's what we have to address. So the mortality rate is 71% for African American women compared to 86%. So we still have that gap, which we're trying to close. And you're going to hear more about that from my colleague later. As far as mammograms, about 40% of black women with abnormalities, when they're found, will never receive follow-up care, which is twice as high a rate compared to white women. They're more likely than white women to delay getting a biopsy. African American women are 5 times more likely to delay getting treatment once they've been diagnosed. And for 20% of African American women, more than 3 months have passed from the time their breast cancer symptoms were first detected and then when they start treatment. And they're more likely to be offered a mastectomy which is removal of the entire breast, versus a lumpectomy. So I just want to give you a little bit of an overview of some of the developments in breast cancer for the past year. One of the trials that we were really excited about this year, and I don't know if you heard about it in the news, is the TAILORx trial, and I'm just going to try to simplify it. First of all, Oncotype DX, for those of you who are not familiar with it and are not breast cancer survivors and did not have this assay done, it's a 21 gene assay. So it's offered generally to women who have early stage breast cancer. You have to be hormone receptor positive. That means estrogen and progesterone. Your tumor has to express estrogen and progesterone and be HER2 negative, and your lymph nodes are negative. And so this assay, your tumor gets sent off to this company, Genomic Health, and they run this assay that looks at 21 genes. And then the company comes back and gives your oncologist what's called a recurrence score, which predicts your risk of developing a recurrence of your cancer. And it's not black and white. So it's not like, yes, it's going to recur over 10 years or no. It's usually a number. And it's either low, high, or there's this intermediate score. And the issue is, what do we do with those women that have that intermediate score? The ones that are low are great because we can say your risk is low, and then your oncologist may prescribe a pill like tamoxifen. Or if it's high, they may say you should go on chemotherapy. But it's that intermediate that we weren't sure about, and you have to kind of use your clinical judgment. And so we wanted to know, what do we do with those? How many of those women really don't need chemotherapy? And so this was the study design, and this is it's very busy, but the bottom line is those in the middle group were randomized to getting either hormones which was like tamoxifen, or getting chemo. And what they really found, and I'll just basically explain to you what happened, is when they looked at disease-free survival and relapse-free intervals, that there really was no difference between the two groups, whether these women took hormones or chemo. So for many of these women, we found they really didn't need to take chemo. So that was really a really big leap, that we found that most of these women really didn't need to take chemotherapy. And so when you look at it by age and you break it down by age, for the women over 50, that's the group on the right, you see that most those curves are overlapping. And so most women over 50 can really be spared chemotherapy. When you look at women under 50, that's where it gets a little, you kind of have to break it down. And so when you think about that half of all cancers are hormone receptor positive, you can really avoid chemotherapy in about 70% of patients. Those that are older than 50 with a recurrence score between 11 and 25, these are just the numbers and how they come about, and how they score these, how the scores come up on the reports. If they have a recurrence score of 0 to 10, which is pretty low, and then younger women with a recurrence score of 11 to 15. And so that's how it's broken down. And then the ones that you should consider chemotherapy in are the ones that have a recurrence score over 26. Those are the high group. And then those that are 50 or younger, the younger women with a recurrence score between 16 to 25. So this was a very, a really groundbreaking study that really has helped, I think will help guide treatment for many women, particularly those that fall in that intermediate category, and also help with also the younger women. But there is that caveat for those younger women that fall in that sort of that higher intermediate category. Those women will probably need to can still benefit from chemotherapy. Does that make sense? Also, our staging, also oncotype plays a role, and there are other, this is not the only assay we use, but this is the one that we use more, that's used more commercially more often in the way we stage patients. I put this slide in because staging is not static. It has changed over the decades. And the last staging that we had, which was the 7th edition, we've used for over 8 years. And this year we changed it. And the reason why we changed it is because we wanted to make it more consistent with the way that we now use genomic testing, like Oncotype, to make it more personalized, to make it more relevant to the way we treat patients. Because you can have 2 patients with the same stage and they're going to do very differently. Their outcome may be very different. So the way we stage patients was usually based on anatomic factors, the size of the tumor, how many lymph nodes were involved, and whether the patient had metastatic disease. It was a TNM. And then we wanted to say there were other factors involved, whether or not a patient was triple negative, their hormone receptor status, and other genes that were involved. And so that it needed to make it more predictive of their outcomes. And so that was the impetus for changing the staging system. It has changed so much that I can tell you I can't remember it. I don't know if any of my colleagues can. I have to keep looking it up every time I stage a patient. And so as of January 1st, the staging system changed to integrate all of that into our staging system. And so I can tell you now that rather than just having the TNM, which is the column all the way in the left, that looks at the size and the lymph node status and whether or not a patient has metastatic disease, we're looking more and more at other factors that have to do with the tumor itself. And so, for instance, on the first, you look at the first line, I don't have a pointer. You can have a patient that's triple negative and have a very small tumor, which is the T1, who could be a sub-centimeter, 8 millimeters. And under the staging system last year, they would have been a stage 1. But this year, they're a stage 2. Because if you're triple negative, which many Black women are, African American women are, those triple negative tumors tend to be more aggressive. So that's going to upstage a patient. And so now that's stage 2, which is more consistent with what we know about triple negatives. But on the bottom, which is circled in red, you have a patient that has a T2 tumor, which means that that tumor is between 2 and 5 centimeters. So you can have a 3-centimeter tumor. No lymph node negative, that's what N0 means. No evidence of tumor spread anywhere. But the genomic profile shows that, excuse me, let me just make sure. Yeah, everything else about the tumor is fine. The grade is low, hormone receptor positive, a low oncotype score. Under the old system, that patient would have been would be stage 2A because of the size of the tumor. But with the new staging system, this patient gets downgraded to a stage 1. So it can work both ways. So I'm going to switch to some advances in surgical treatment, which we work with, that also involve our colleagues in radiology. The way we take out specimens in the operating room for patients that have non-palpable lesions that we can't feel. We often, the old-fashioned way of taking it out would be that we'd have the patient come in early, they'd get a wire put in, it's called a needle localization, and not fun for us, not fun for the patients. They don't like getting stuck, and we're often waiting for the radiologist to finish the procedure because we don't want to lose time in the operating room. And so, and also, there's also technical issues with doing a needle localization that can make things a little complicated. But that's the way it's been done for years. There have been several techniques that have been developed to try to replace needle localization. The first one was radioactive seed localization, and a lot of places still use this procedure, and that's just using a seed that replaces the wire, and it's tiny. It's put in. It can be put in up to, I think, 6 weeks prior to the procedure by the radiologist, and then you use a probe, the same probe that you would use for a sentinel node. It detects I-125, and then you just use the probe to pick up to detect the lesion that way. There's some pluses and minuses with that. Obviously, you don't have to worry about a wire, but there's a chain of custody with this because you have something that's radioactive. So you cannot lose this seed. Every state has their state laws about radioactive materials. It has to go into a special bag. Pathology has to recover the seed, and then it has to go back to radiation safety. So I can tell you that there have been programs across the country that have been shut down because they just can't, because they lose the seeds. So there's some pluses and minuses to that. But you always have to document that you have found that seed. We always x-ray the specimen. And so you have the lesion, you'll have the clip from the biopsy, the original biopsy, and then you have the seed. So you have to document it. So when we were discussing what we would use to replace needle localization, this was not something that was palatable to us. So we decided to go with something called a scout, Savvy Scout. This is what a console looks like. Instead of using radioactivity, it works on radar. You have something called a deflector that's similar to the seed. It looks like a biopsy clip, and the radiologist will put that in, and it can be done anytime before the procedure, which is nice. And so there's a handpiece that we use in the operating room that works to detect the radar. and it works very nicely. And there's a very easy, it's very easy to learn. This is this, on the right, you can see the size of the dime. The reflector is tiny. That's how big it is. And so it can be, literally, it can be put in, and before it was FDA approved, they said it had to be put in a week before. Literally, it could be done a month in advance, or even more than that. It can be seen on ultrasound, mammogram, or MRI. And you can see a specimen radiograph on the top right with the specimen, with the clip, and the deflector. Let me see if I can show you a video of how it works. There's no sound. So, okay, here it is. So what's nice also is with the console, it will also tell you how deep the lesion is, and it also emits a sound. So the closer you are to it, the louder the sound gets. So it helps you localize the lesion that way. So it'll tell you the number, it'll give you a number in millimeters. It's not always accurate, but it helps. The radiologist will also give you film so that you know you can, just like with a needle localization, so we use that to guide us as well. And that'll help us with planning our incision. And then once we remove the specimen, we check again just to make sure that we actually have the lesion, and we can, by doing that, what we do is we check again with the handpiece to make sure we have the signal. And then we x-ray the specimen and we confirm with the radiologist, which is nice. And honestly, it's helped in so many ways. The patients are happier, the surgeons are happier, the radiologists are happier. And it has increased OR efficiency, which is really nice. Yes?
So this takes the place of what was normally done a couple of hours before surgery?
Yes.
Yeah.
Mm-hmm. Yeah, so the patients don't have to come in at like 6 o'clock or to get that wire put in. Yeah, they just come in a little bit later. They don't have to get that wire put in. This replaces it. Yeah, which is nice. Yeah. So they can come in anytime before the day of surgery to get that done, get this procedure done. Yeah. Just some final thoughts, because I want to let my other colleagues speak. There's some other barriers that patients have to go through. Dr. Noel is going to talk about this. Financial is a big part of it too. I mean, it's not just getting patients in for screening, and we know that. The July issue of Cancer had an article about this. 30% of women who are at least somewhat worried about their finances due to their breast cancer diagnosis. And 14% said they lost more than 10% of their household income while being treated for breast cancer. And 17% spent more than 10% of their household income on out-of-pocket medical expenses. I don't think we really appreciate the impact that breast cancer has on patients and their financial status as they're going through their treatment, and whether or not patients actually have insurance or do not have insurance. Black women in particular who are diagnosed with breast cancer are more likely to have lost their private insurance, lost a job, and had financial problems that cause them to delay or refuse recommended treatment. and also transportation problems, which cause them to delay recommended treatment. And we all know that because we see that here when we treat our patients. And those are the barriers that we're trying to overcome. So we have a very full schedule, and we're going to move along. We're going to switch the order a little bit, and you're going to hear from our nutritionist, who's going to speak about the impact of nutrition on cancer treatment. So I thank you so much, and we'll have a Q&A at the end of this first session. Thank you so much.